Hello, everyone, and welcome to the July 2025 episode of Diabetes Care on Air, a fun way to bring the research in diabetes care to life. I'm Alice Cheng from the University of Toronto.
And I'm Mike Rickles from the University of Pennsylvania, and we are your co hosts for this podcast series.
Well, welcome to July, everyone. July is a month of anniversary celebrations. July 1st is Canada Day, and this year actually marks our 158th birthday. So happy Canada Day, everyone. And for the United States, July 4th marks its founding as a nation. Happy 4th of July, everyone. And Mike, I believe you told me before that your wedding anniversary is also in July.
Yes, Alice, coming up on the 20th.
So happy anniversary to you, and I hope you're ready and have some wonderful surprise planned and lots of gifts. And this year in July, we are also celebrating a milestone for the National Institute of Diabetes and Digestive and Kidney Diseases, or NIDDK, of the United States National Institutes of Health. Mike, can you say a little more about this?
Indeed, Alice. This year marks the 75th anniversary of NIDDK, which was originally established by Congress as the National Institute of Arthritis and Metabolic Diseases in 1950 and assumed its current name and mission in 1986. NIDDK's mission follows a mandate to improve health and quality of life by conducting and supporting medical research and research training and disseminating science-based information on diabetes and other endocrine and metabolic diseases, as well as on digestive and kidney diseases. And to celebrate its 75th anniversary, this month's July issue of Diabetes Care contains a collection of invited articles highlighting a few examples of the tremendously impactful programs sponsored by NIDDK in its more recent tenure. These include updates from DCCT EDIC, GRADE, the Diabetes Prevention Program, TrialNet, TEDdy, the Diabetic Foot Consortium, and others. Additional NIDDK programs are also being covered with invited articles appearing in this month's issue of our sister journal, Diabetes.
And that's wonderful, Mike, that NIDDK is being celebrated as it should be. And for those of you interested in learning more about the history and future plans at NIDDK, I want to alert our listeners to a commentary in this issue entitled NIDDK Celebrating 75 Years of Advancing Diabetes Research, written by Dr. William Cefalu, Director of the Division of Diabetes, Endocrinology, and Metabolic Diseases, and colleagues at the NIDDK.
Thanks, Alice. Now, for the rest of this episode, we'll be interviewing authors of feature articles from the July issue of Diabetes Care and run through our popular exchange segment where we will each pick 3 articles of particular interest to us.
So let's get on with it. One of the feature articles from the July 2025 issue of Diabetes Care is a consensus statement of the ADA entitled Metabolic Dysfunction-Associated Steatotic Liver Disease, or MASLD, in People with Diabetes, the Need for Screening and Early Intervention. I am joined now by Dr. Kenneth Cusi, endocrinologist and professor of medicine at the University of Florida in Gainesville, Florida. Thank you so much for agreeing to be part of this podcast, and a huge congratulations to you and your colleagues for producing this consensus statement.
Well, thank you, Alice. It's an honor for me to be here, and hopefully we'll have some fun in a few next minutes on this topic.
I'm sure we will. So this is a huge document and clearly a labor of love with 19 authors, 271 references, and some really fantastic figures and tables that are easy to follow. I encourage all of our listeners to have a read for sure. And obviously, we'll not be able to cover all of the content from this consensus statement during this podcast interview, but I think we'll be able to give a high-level summary, and that will whet the appetite of our listeners to take a deeper dive. So let's begin with a big picture question, Ken. Why is this consensus statement necessary from a diabetes organization to a diabetes audience?
Well, that's a great question. When I studied in medical school, they told me, well, the liver collects fat and sometimes liver enzymes are elevated, and that's okay. But then about 20 years ago, a young gastroenterologist in training told me, what do we do with people with diabetes and elevated liver enzymes? So I said, I don't know. I started looking into this, and the emerging literature was that this is a growing problem. So we set out to look at this more carefully, and we did a clinical trial with a diabetes medication that helped. And progressively, I remember writing in a journal called Practical Diabetology, I think by the ADA. I said we have to start screening for this because it's a big, big problem. That was in 2008. And here we are only 17 years later with that dream come true. But the numbers, just for the audience, are that if you just take 100 people with type 2 diabetes who have never heard the word MASLD or their doctors, 70%, 7 out of 10 have too much fat in the liver, what we call steatosis. That's why we don't do a liver ultrasound, because the chances are that they will have it. And more if you have also hypertension, obesity, and so forth. But the real problem is not identifying steatosis. The problem is identifying the scarring that happens in the liver, which we call fibrosis. And not any fibrosis, but when it's in a stage that's moderate to advanced. And that is, for us diabetologists, it's like saying you begin having proteinuria. So it's a very good analogy, but it'll take 10 to 20 years to get to end organ damage, but it is completely preventable. And we'll talk about that later. So we want to identify that about 20%, not a small number, 1 in 5, that are on a pathway to cirrhosis, and we will identify some with cirrhosis already. So the statement in summary is because we finally identify the liver as another end organ that is under significant stress in diabetes, not only type 2 diabetes, but we also presented at the ADA recently that in people with obesity and type 1 diabetes, they have the same clinical picture, which is about a third of our people with type 1 diabetes. So a growing problem.
Okay. Well, you've convinced me that it makes sense for this to be something that we're listening to. So for those of us who are not well versed in the world of liver, it seems like the names keep changing, right? I mean, I remember fatty liver, and then it became NAFLD, and now it's MASLD. And there also seem to be so many of them, right? There's MASLD, and then there's MASH. So can you help us define and categorize these names, starting with perhaps what the umbrella term should be, and then what its derivatives are?
Yeah, that's another. I apologize to all the listeners because it is difficult. And the evolution was that, and this is very carefully explained at length in the document. There's a table that was included explaining why, and tables defining everything that we won't have time now. But fatty liver, which is called non-alcoholic fatty liver disease, the big driver was that first everybody would agree it was a bad name, saying it is what is not it is before. Because before, only alcohol was, I would say in 30 years ago, was identified as a risk factor other than viral hepatitis or toxicity from drugs. So it was a bad name, and there was an effort to try to give it some link to what was going on. The pathophysiology is fairly complex. I personally would have preferred to call it, I know, something related to lipid toxicity, because it's a toxicity induced by sick fat, frequently happens in obesity, but also in overweight, that fatty acids are constantly getting into the hepatocyte and causing metabolic damage by accumulation, not of triglycerides, but also toxic lipids called deacylglycerol, ceramides, and others. But back to your nomenclature question. So that name was then changed to something that had the name of metabolic. And this is a big multi-association debate for 2 years that included mainly hepatologists, some endocrinologists, and others. And the idea was to say metabolically associated dysfunction, things like metabolic syndrome of the liver. But it's a little bit more than that, because it's not about steatosis, it's the inflammation and fibrosis. Now, the umbrella is called steatotic liver disease. It's fatty liver, but in Latin, steatotic liver disease. And it involves not only what we know as NAFLD, that is that fatty liver, plus one feature of the metabolic syndrome. This audience would know the cutoff for overweight, obesity, prediabetes or type 2 diabetes, hypertension, and dyslipidemia. So it's the old NAFLD or fatty liver plus one metabolic syndrome feature. That is a big umbrella of people who drink less than 20 grams if you're a female or 30 grams if you're a male. Those differences in cutoffs have nothing to do. That probably was a predominant male-driven committee, but that women metabolize alcohol less and they have a smaller surface area. So the same amount of alcohol will be more damaging to that liver. So MASLD, this is the big umbrella. If you drink less than that amount. Another important thing was what we call the combination of metabolic disease plus alcohol. But people who don't drink as much as to be classified as having alcoholic liver disease, it's 60 grams and above a certain amount of time. And there are several cutoffs that are explained in the context. But there's a lot of people who don't drink that much, but not that little, and also have obesity and diabetes and metabolic. Together, alcohol, and we won't have time to talk about it, but alcohol in that setting is very harming. You shouldn't drink if you have that. And then there is really the inflammation. So you have fat, steatosis, but this drives inflammation, we think due to mitochondrial dysfunction, endoplasmic reticulum stress, other factors. So that's the MASH. And then you have different degrees of fibrosis. What people should remember is a term called at-risk MASH, which is really at risk of cirrhosis MASH. This means you have a degree of scarring of the liver, fibrosis, that it's like having proteinuria for chronic kidney disease. And that's moderate to advanced fibrosis. That can only be determined at least with transient elastography, what your liver doctors have used more frequently as a FibroScan or shear wave elastography, or by an MRI elastography. So massively big term with MetAld, if there's some alcohol involved. MASH, if you have the inflammation can only be very accurately measured by biopsy, but there's some imaging and blood tests that you can measure too. And then you have cirrhosis, right? So did I confuse you enough or
No, no, you explained it very well, but I would encourage our listeners, if you're a visual learner, the figure that's within the document is really helpful to help frame that as well. But it's exactly what you just described. So nope, that's clear. Thank you. Now, as you mentioned earlier, MASLD is common amongst those living with prediabetes or type 2 diabetes. And some of those with MASLD may have MASH, so the actual inflammation piece, and some may have at risk or even cirrhosis. Now, the whole purpose of screening, early diagnosis and intervention, is to reduce liver outcomes, right? Like cirrhosis, like hepatocellular carcinoma, and possibly non-liver outcomes. So how do we diagnose disease? Like what tests should we order?
that's a great test. So again, there was initially, I think, or even now, some confusion. Are we diagnosing steatosis or something else? As I mentioned earlier, nothing bad about diagnosing steatosis, but the ultrasound cannot quantify the amount of scarring in the liver, the amount of what we call fibrosis. So you can just jump into that. Now, one little caveat, if you already have elevated liver enzymes, elevated transaminases, that is something that you need to seriously rule out. Some simple things like viral hepatitis or excess alcohol intake, and then refer to your pathologist if that's been there for at least 6 months or sooner, depending on the elevation. But what we're really looking is fibrosis. So this was a difficult task, but there's not a single test that can identify this. Remember, there are really three biologies: fat, inflammation, and fibrosis. This is like a domino effect where somehow at some point the fat triggers inflammation and the inflammation puts on mechanisms for fibrosis. But it's hard to identify the inflammation. There are some tests like the CT multiscan or a blood test called NIS2. I don't want to drown you in a soup of terms They're all in the manuscript. But what we want to do is identify fibrosis. So the test is called Fibrosis 4 Index. It has 4 elements that I'll tell you in a moment. And then if that is positive, then that's a test that you're going to need to confirm. It's a broad test, and it is composed of your age of your patient, plus aminotransferases ALT and AST, and platelets. So 4 components. And it really was developed by the viral hepatitis world about 20 years ago. And it has good specificity, means that if it's elevated, you should worry. If it's on the lower end, you have a lower probability, but it's not a perfect test. Some people may have liver disease with a lower number, but it's important to know that because of age, if you are in the extremes of age, either very young, you may underestimate, or if you're very old, above age 75, you're going to have more false positives. So FIB4 followed by an imaging test of the liver called transient elastography.
So let's talk about the FIB4 then. And that I think we should be doing as diabetes practitioners. So if we walk through the thresholds, starting with the 2 extremes, if the FIB4 is less than 1.3 and those with FIB4 over 2.67, what should we do for those?
Great question. Alice, it seems you are an expert on this. I can see that you've gone through this and you're, I know, an excellent clinician. So if you just want to remember one number, remember 1.3. Below 1.3 and equal or above. Because in primary care or in endocrine clinics, it's going to be less than 5% that have a value above 2.67. Very rare. In hepatology clinics, it's going to be more common. But for us, remember 1.3. Below 1.3 says that you have a lower chance of having this at-risk MASH, this moderate to advanced fibrosis. Not a perfect test, because the test initially aimed to get the people with pre-cirrhosis or cirrhosis, advanced disease. And it has been a little bit repurposed in this MASLD field to catch people with moderate, and it fails a little bit there. So for the audience, if you have somebody who has diabetes, obesity, and dyslipidemia, and mildly elevated liver enzyme, and a FIB4 of 1.3 or 1.2, I think you should still send them to your hepatologist, because this is a matter of common sense. Take the FIB4, but not in isolation, but within the clinical context. The same if you tell me somebody who's, I don't know, 45 with no risk factor and has a FIB4 of 1.3, I will be a little bit more cautious in doing that. So common sense is clinical, the art of medicine here. And again, these are not absolute numbers. I mean, we are very familiar with A1C, and A1C has a lot of caveats. If you're anemic, that A1C is not going to be good, or have thalassemia and so forth. So no test is perfect. And a 6.5 is a high specificity number, but there's many people with diabetes by an oral glucose tolerance test with an A1C of 6.2. So common sense. Now, 1.3, equal or above 1.3, you begin worrying. Above 2.67, that person can go straight to the hepatologist for evaluation.
All right, good. So under 1.3, may not have to worry, but use common sense. Over 2.67 goes straight to hepatology. So now begs the question, what do I do with the in-betweeners?
Well, I would have to say, I know, Alice, you don't want to hear this, but the vast majority of people with at-risk MASH are going to be between 1.3 and 2.67. And obviously, as it gets closer to 2.67, the greater your risk. I would say definitely if it's above 1.67, there's a very high chance that this person has moderate to advanced fibrosis, okay? But remember, 1.3 should make you wonder if this person could have a problem. What to do? Well, you have to do a second test. So in the United States and maybe Europe, most hepatologists use what's called vibration controlled transient elastography, or elastography in short. This is by a given company called, some people call it straight FibroScan. But if you don't have that, shear wave elastography from your ultrasound can also give you some idea. So it's a test. Some papers have shown very good correlation. And then there are other companies that have other imaging tests. Bellacour has one. There's several. And you should use that, whatever you have, as a second test to do this. Now, if you don't have any test, there's also a blood test called Enhanced Liver Fibrosis, or ELF, but it's a proprietary test that is relatively expensive in the United States. So you need to consider that. Or you just send them to your liver doctor. He will decide what will be the most cost-effective approach. Another thing you can do is to make sure the patient doesn't have viral hepatitis or alcohol abuse. You should become familiar with the audit score. The full one has 10 questions. There's an audit C, only 3 questions, and have that conversation with your patient. So I hope there are a number of additional tools your liver doctor has in terms of more blood tests and MRI imaging and measuring fat, measuring fibrosis. But I don't want to put you to sleep now. But all of that is explained in the guidelines and has very simple tables, which you can copy and put in your office to know what the cutoffs mean and all that. If you do an elastography test, remember just the number 8. If that elastography test, the liver stiffness measurement, which is, say, your equivalent of fibrosis, is 8 or greater, that should be a point for referral to your doctor, not the amount of fat.
Okay. Now, let's shift gear and talk about treatments. Starting off broad categories, remembering that we're speaking to a diabetes audience. So, what are sort of broad categories of treatments? And then we can go into pharmacotherapies.
Very simple. There are those that are related because the majority of people with MASLD have overweight or obesity. Lifestyle changes that promote weight loss are the cornerstone of treatment, same as for type 2 diabetes and other metabolic conditions. So we're going to talk about that: lifestyle, diet, and/or bariatric surgery. And then the other would be the optimization of diabetes, which the American Diabetes Association this year in the pharmacological management recommends drugs that can lower glucose and improve the liver. And then there's 2 drugs have phase 3 data of benefit in MASH.
So let's talk pharmacotherapies now in the diabetes world, just because I'm not sure how many of us in the diabetes clinic will be initiating those liver specific drugs.
Yeah.
However, there are therapies that we can offer our patients living with diabetes that have some data behind them. So can you speak to us about those?
Well, yeah. So what happens in people with diabetes and MASH, there are options that are more expensive and cheaper. We have shifted away from choosing drugs by how much they lower the A1C to treating disease states. And this has been for a while now, since we have SGLT2 inhibitors for heart failure and chronic kidney disease. We have some GLP-1s also that have an indication for chronic kidney disease, like semaglutide, or sleep apnea for like tirzepatide, to weight management specific medications, to drugs that have shown benefits in MASH. And there are 2 classes of agents, what I call GLP-1s in general, and the evidence, some small studies with liraglutide at the beginning, and more recently semaglutide with well done phase 2, and now a recent phase 3 study called Essence that reported, actually was published in the New England a few weeks ago, showing clear benefit on the inflammation, what we call steatohepatitis, and on the fibrosis. And others are coming, and you've been at the ADA, many GLP-1 dual, triple agonists, but tirzepatide, GLP-1 GIP agonist, has shown to also improve steatohepatitis and fibrosis, and survodutide, also a GLP-1 and a glucagon agonist. But in phase 3, only semaglutide has shown that benefit. Talking about other diabetes medications, I am a very strong proponent of pioglitazone. Pioglitazone is in the United States and many countries a generic. I give talks many places, and they cannot afford GLP-1s for the most part. So pioglitazone has become by default the only other option. And if you combine it with lifestyle changes, or you combine it with an SGLT2 inhibitor or a GLP-1, you have net weight loss. Or if you start 15 milligrams, as used in many places, there's minimum weight gain, if any, and then you can titrate up. So in the context of a lifestyle program, weight is tolerable. There's long-term issues with fractures at the higher doses, so you want to do bone densities to start. And then the issue of bladder cancer has kind of subsided. 18 of the 23 studies or so have been negative. So in general, and then vitamin E has been well tested in the PIVENS trial, published in the New England 2010 for people without diabetes. Again, has an ongoing debate about the risk of prostate cancer or cardiovascular disease, but it's an inexpensive option. I think more valuable if you have advanced disease.
So the last question I have for you then is, how should this care be delivered, right? I think you've convinced us that in the diabetes space, we need to think about it. We need to look for it. We should at least do a FIB4 and then send people for additional imaging, however we can, based on where we live. But who else needs to be involved? Who are the necessary members of this interprofessional team?
Yeah, so it is difficult to build interprofessional teams. Maybe an easier word would be interprofessional networks, where at least you know where to send your patient, who you can talk at least over the phone. And it is basically the same diabetes care team, but where we give a more prominence to the hepatologist and maybe weight management, because here, more than anything, weight loss can really reverse the damage to the liver. And don't forget the option of bariatric surgery. So these interprofessional teams that are well described what each one has to be doing are going to deliver much better care. In the United States, it is a little bit of a fragmented healthcare system, and that is sometimes difficult, but at least choose 2, 3, or 4 key partners that you can work with to reach this, because we don't want to get cirrhosis or liver cancer, which we haven't talked about yet.
Yeah, no, you're absolutely right. So we're out of time, Ken.
Oh, we ran out of time.
So within the consensus statement, there's also a whole section on how to manage diabetes in the context of cirrhosis and the link with hepatocellular carcinoma. But like I just said, I don't think we have time to dive into those parts, but I would strongly encourage our audience to take a closer look at this document because, as I mentioned in the beginning, there's some really fantastic figures and tables that I will be copy and pasting into things that I can find quickly.
I'm so proud of you.
So,
You know that.
so thank you for that. Huge thank you to you for joining us and teaching us so much today. And of course, to you and your colleagues for creating this consensus statement. We need to know about this as a diabetes community, and we need to take action. And I think that came out loud and clear in your document. So I encourage our listeners to read the full article in the July issue of Diabetes Care. And once again, thank you, Ken.
Thank you so much. Remember, once you have cirrhosis, it is game over. And today we can completely prevent this. I mean, cirrhosis is difficult. Quality of life is very challenging. They're prone to hypoglycemia. And regarding hepatocellular carcinoma, we forget to tell people with diabetes that they have a 3-fold higher chance of liver cancer, and it is because of the link with NASH. So thank you, Alice. Remember FIB4, the value of 1.3. And I'm sure this week you're going to identify someone who you could have missed before hearing this podcast. And Alice, thank you for this opportunity. It's been really a lovely conversation.
In the July 2025 issue of Diabetes Care is a feature article entitled A Comparative Analysis of Glycemic Metrics Derived from 3 Continuous Glucose Monitoring or CGM systems. I'm delighted we have joining us the article's first author, Dr. Guido Freckmann, and contributing author, Dr. Stefan Pleus. Dr. Freckmann is director of the Institute for Diabetes Technology at the University of Ulm in Germany, where he works together with Dr. Pleus, who is the current chair of the International Federation of Clinical Chemistry and Laboratory Medicine, or IFCC, working group on CGM. Welcome, Guido and Stefan.
Thank you very much for the invitation, Michael. We are very overwhelmed that our article has received so much recognition, and we have been active in diabetes technology research for many years, especially with CGM and BGM studies, but we have not yet made it into a front page of diabetes care. And I'm really delighted to be here today with my colleague and to be able to provide a few more insights into our study.
Yes, thank you very much for the invitation.
And first, congratulations to you both and your co-authors on your feature article. To get us started, your team previously reported on the accuracy of 3 current CGM systems in individuals with type 1 diabetes, and now in the present study evaluated whether differences in accuracies affect the CGM metrics we all now use in clinical practice for guiding therapeutic decision-making. Guido, could you please briefly describe how the parent study was conducted?
Thank you very much, Michael. Of course, I can do this. The study was really designed to demonstrate the feasibility of a study procedure for CGM evaluation studies previously published by the IFCC working group on CGM. And we included 24 people with type 1 diabetes into this study who were 3 sensors in parallel, a sensor of each of the 3 systems. It was a G7, Libre 3, and a Simplera sensor in parallel at their arms. The participants came to our institute on 3 days during the 14-day study period and carried out frequent comparator measurements on venous and capillary blood to assess accuracy. And we used, as mentioned, the clearly defined study procedures based on the working group recommendations. And these procedures are challenging the systems by first bringing study participants into a hyperrange with a glucose excursion post-meal and then into a short hypo with a rapid drop. This allows us to cover the entire measurement range and also test rapid rates of change, which also occur in real life, especially of type 1 diabetics. And in daily life, it's particularly important to be able to rely on CGM. We also use different comparison methods to laboratory methods for venous blood measurements and BGMS for capillary blood measurements.
All right, and turning to you now, Stefan, what were the findings previously reported regarding accuracy, and how did those findings prompt the present analysis of the current study?
So accuracy is not that simple, as manufacturers play a role here, and the accuracy of a CGM system that you see in a study very much depend on the conditions under which you test the CGM system. In general, we observed that the accuracy in our study was a little bit worse than what the manufacturers claim for their devices, but this is probably due to what Guido said, the more challenging study procedures in our study. What we also could see was that the accuracy that we found, for example, the MALD result, was heavily dependent on which comparison we used. This is also something that should be, well, kept in mind when interpreting accuracy results. And we have done a lot of these studies in the past, comparing different CGM systems in a head-to-head design. And we often found differences in the accuracy. And on 2 occasions, we also tried to translate these differences in accuracy also to differences in CGM metrics. But it's very hard to communicate these results and their significance to the users like patients and clinicians. But we want to reach these users. So what we did now was we expected differences in the accuracy, and we chose the current generations of the 3 big manufacturers so that we can make a current statement or a statement about the current CGM systems.
Okay, so now turning to the results of the present analysis, Guido, what did you find?
So we find in the clinical parameters what we have already seen in the accuracy analysis, which was previously published, a relatively good match between Dexcom and Libre, but a different, I call it different picture for Simplera. That means for the same patients, we have seen differences in these sensors. Even the median across all participants showed significantly higher time in range and higher time below range for Simplera. So there was a negative bias seen, and this reflected a different glycemic situation here. And this can also be seen in the mean glucose, the GMI, etc. To name just one number, the GMI in our study differed by 0.4 percentage points in median, which could certainly be clinically relevant. At the individual patient level, there were even larger differences in some cases.
So sensor accuracy then, it appears, can bias these CGM metrics that are derived from typically 14 days of continuous glucose monitoring data. Stefan, how might the differences detected between sensors in your study potentially impact clinical decision-making in practice? And as a part two of this question, I'm also curious on your thoughts on whether continuing to measure hemoglobin A1C in the laboratory can help with guiding interpretations for the individual patient.
Yeah, so there are clinical targets for these CGM-derived metrics, as we all know, and our results indicate that the specific CGM system used by a patient might affect the assessment of the therapy quality in these patients. So, for example, one of our participants had a time below range of 2% with the Dexcom G7 and 8% with the Simplera. If that were a patient in a diabetes clinic, the HCP would likely be satisfied with a 2% time below range, but he would also like to strategize with the patient how to get the 8% time below range more manageable. And it's not only the HCPs where these differences have an effect, but also in the self-management by the diabetes patients. Because if the values that are displayed in real time to the user can show such big variations or differences, this could lead to different actions or even non-actions depending on where your current values are. So this is where HbA1c comes in again. Like you said, HbA1c also has limitations, different physiological impacting factors, but at least there is a standardization how to ensure that results measured in different labs are comparable. So that is really helpful with the HbA1c, and that is missing in the CGM systems.
Yeah, and I know in my own practice, I like having the hemoglobin A1C because in an individual patient, their GMI derived from the continuous glucose monitor may be on average higher or lower than their A1C in the lab, but knowing what that difference is helps me to not overreact if it's off the recommended target, knowing what their relationship typically is. And the other thing that comes up a lot in practice when you say the level of the patient, how they're self-managing and dealing with discrepancies they might find between their sensor glucose and if they check a capillary blood glucose. How does calibration fit in now? Both Dexcom and Medtronic sensors allow but do not require calibration with a finger stick blood glucose. And I know many individuals with diabetes prefer not to have to do a finger stick and calibrate a sensor, but could periodically calibrating the sensor improve accuracy? And did you look at this in your study?
Yeah, that's a very good question. So I would say yes, theoretically, a calibration can compensate for the bias, but it has to be done or performed in a proper way. And the problem is if errors occur during calibration, there is also a risk of things making worse. And in our study, we did not calibrate the systems to keep it comparable for all. And so I can't say anything specific about the influence of calibration on accuracy in our study because we have not performed it. And our impression is that for at least here in Germany, many CGM users don't carry their BG meters with them all the times. So it's not even clear how many CGM users are actually aware of their personal system's inaccuracies. But principally, calibration, if done in a proper way, can reduce a potential bias if you use an accurate glucose meter.
Okay, and also wanted to ask about discussion your article towards better alignment of glucose results from various continuous glucose monitoring centers. Can you share some thoughts on where we might go in the future and provide any additional takeaway messages for our listeners?
So we think that we urgently need more standardization for CGM accuracy evaluations. HbA1c measurements are standardized, but it took a long time to get where we are now. For blood glucose meters, we have an ISO standard and FDA guidance documents with detailed test protocols and minimum acceptance criteria. And we have been campaigning with the IFCC working group to establish a similar thing specifically for CGM systems. And we are now very advanced in our activities. Hopefully, we will be able to publish a working group proposal later this year. And in that proposal, we want to explore how CGM performance studies should be carried out, which specifications should apply to the study design, to the comparison methods, and ultimately also which is a fitting set of minimum acceptance criteria. And with our proposal, we hope that we can engage the manufacturers and convince them that it's important to align the results of different CGM systems. And we have done a lot of work within the working group in recent years. We have carried out studies and published research articles to build a scientific basis for these recommendations. So we are thrilled that our article in Diabetes Care has received so much recognition because it's now widely discussed that we need to do something with CGM systems. CGM systems work, they're good, but they can be better. And everybody involved, the manufacturers, authorities, researchers, and the users must work together to get to that goal.
Drs. Guido Freckmann and Stefan Pleus, thank you so much for sharing your expertise with us today. Your study is so important in helping us all to understand the performance of the latest technologies used for glucose monitoring in clinical practice. I encourage our listeners to access the full article in the July issue of Diabetes Care.
Let's move on now to our rapid exchange segment, where Mike and I chat about some of the articles we found particularly interesting this month. Mike, can you get us started?
Sure, Alice. This time I'm going to try to follow a theme of glucose dysregulation leading to diabetes. My first pick examines a 1-hour glucose during a standard oral glucose tolerance test, or OGTT, that we discussed a few episodes back in this podcast series. Dr. Mohammed Abdul Ghani from the University of Texas Health Science Center in San Antonio and colleagues examined the ability of the 1-hour glucose to predict progression to prediabetes among normal glucose tolerant individuals. Of over 1,500 subjects with normal glucose tolerance at baseline who participated in the San Antonio Heart Study, a quarter progressed to prediabetes 7.5 years later. The 1-hour OGTT glucose was the strongest predictor for developing prediabetes, with risk already increasing at values above 120 milligrams per deciliter. And the value greater than 155 milligrams per deciliter that we've heard about before was associated with a more than 5-fold increased risk of having diabetes 7.5 years later. So these findings add additional support for an elevated 1-hour glucose representing an early marker of deterioration in glucose tolerance that precedes traditional prediabetes criteria.
And what you've just described there, Mike, fits nicely with the International Diabetes Federation statement on what's been termed intermediate hyperglycemia that they released last March, citing a 1-hour OGTT glucose of, as you mentioned, greater than 155 milligrams per deciliter, which is 8.6 millimoles per liter, for diagnosing intermediate hyperglycemia and citing the 5-fold increase of progressing to diabetes, as you mentioned. But they also say in the IDF statement that a 1-hour OGTT glucose greater than 209 milligrams per deciliter or 11.6 millimoles per liter is indicative of diabetes. But what you just described of the threshold of 120 milligrams per deciliter, which is 6.7 millimoles per liter, is almost like a pre-diabetes kind of level. So I think useful for us to be aware of, because if people happen to get OGTTs done, to sort of know that, okay, this is somebody that we just maybe need to pay a little bit more attention to. Well, for my picks this week, Mike, there actually is no theme per se, or at least I couldn't come up with one. So let me tell you about my first pick. So following on somewhat from the NIDDK celebration in this month's issue, Dr. Shi-Chen Kuo and colleagues from the University of Michigan evaluated the real-world cost-effectiveness of the National Diabetes Prevention Program, or NDPP, in people with prediabetes in a large workforce with employer-sponsored health insurance. They performed analyses using individual-level health insurance claims and survey data for nearly 6,000 adults with prediabetes, 575 of whom enrolled in the NDPP, and 5,373 did not enroll. They looked at direct medical costs for the year before NDPP and for the 2 years thereafter. Compared to non-enrollees, each NDPP enrollee had an average reduction of $4,552 in 2-year total direct medical costs. The savings primarily were related to hospitalizations, outpatient visits, and emergency room visits. There was no difference in EQ 5D5L utility scores or quality-adjusted life years gained over 2 years. They did an uncertainty analysis, which showed that enrollment in NDPP had an 88% probability of saving money and 84% probability of being cost-effective at a willingness to pay threshold of $100,000 per QALY gained over 2 years. Therefore, the authors concluded that enrollment in NDPP was likely to provide cost savings.
Well, that's really welcome news, Alice, because as we learned in last month's issue of Diabetes Care, enrollment rates in national diabetes prevention programs is very low in the United States, and having evidence now of cost savings will hopefully spur the development and implementation of greater access to an increasing number of programs. My next pick, along the theme of glucose dysregulation leading to diabetes, and fits as well in our need for having better diabetes prevention services, is aimed to determine a metabolomic signature associated with incident diabetes in an indigenous American population. Dr. Venkatesh Murthy at the University of Michigan in Ann Arbor and colleagues defined circulating metabolomic signatures in 446 indigenous Americans who had measures of peripheral glucose disposal and suppression of hepatic glucose production available from insulin clamp experiments, and then validated these metabolomic signatures against glucose tolerance and diabetes risk in 2 larger independent cohorts. The metabolite-based scores of insulin action were strongly related to incident diabetes in the discovery as well as validation cohorts, and with surrogate measures of insulin resistance in the validation cohorts. Importantly, these associations were BMI and glucose independent, and so suggests that combining molecular and clinical phenotyping might allow for even earlier identification of potential disease mediators prior to diabetes development.
I love these studies because it seems to, each and every single one of them, get us a step closer to true precision medicine and being able to really evaluate the individual sitting in front of you and what their specific risks are. So very cool. Thank you, Mike. My next pick is perhaps a selfish one, and I will choose to interpret it to my own benefit. That's going to make sense as I explain what it's about. So my next pick is by Dr. Xinyi Li and colleagues from Harvard University, who examined the association between total alcohol intake and drinking pattern with type 2 diabetes among 3 cohorts: the Nurses' Health Study, the Nurses' Health Study 2, and the Health Professionals Follow-Up Study. Former regular drinkers were excluded from baseline non-drinkers. Over 30 years of follow-up, 20,551 type 2 diabetes cases were documented among 200,969 participants. This is what they found. Total alcohol intake was associated with a lower risk of type 2 diabetes, either using non-drinkers or 0.1 to 4.9 gram per day as the reference. That's right, friends, you heard it right. Alcohol intake was associated with a lower risk of type 2 diabetes. Interestingly, it was the frequency of drinking that most correlated with the reduced risk. Compared to drinking 1 to 2 days per week, the hazard ratios for developing type 2 diabetes amongst those drinking 5 to 6 days per week was around 0.73 for the 3 cohorts. For women, the inverse association began at drinking 1 to 2 days per week, and in men, at 3 to 4 days per week, and was strongest at 5 or more days per week, regardless of whether you were drinking less than 10 grams or 30 grams or more per day. Now, bear in mind, in these cohorts, there were very few participants who drank more than 45 grams per day, which is equivalent to 3 standard drinks. So these were, in general, light to moderate drinkers. So therefore, the authors concluded that light to moderate alcohol consumption, especially regular light drinking, was associated with a lower risk of type 2 diabetes in both men and women. Now, I should point out, and this is the part that I'm choosing to ignore, but I should point out that the authors explicitly state that they do not suggest initiating alcohol consumption as a means of preventing diabetes, especially among younger adults. And they also remind us of the detrimental effects of high alcohol consumption on cancer, accidents, and mental health issues. However, I'm going to pretend I didn't read that last part, and I'm just going to go with regular light drinking lowers your risk of type 2 diabetes.
Everything in moderation. I think that's the
Yes,
key,
that's the
isn't it,
motto,
Alice? So less is more, but
That's right.
let's not be eliminators. Okay. My last pick comes full circle, at least in my mind, for the theme of glucose dysregulation leading to diabetes, since it addresses cystic fibrosis related diabetes, or CFRD, a unique form of diabetes affecting a rare disease population that very early on brought attention to the physiologic importance of this 1-hour OGTT glucose measure we've been discussing for identifying early defects in insulin secretion. In this issue, Dr. Celia Kohler, together with senior author Dr. Christine Chan from the University of Colorado in Aurora, and colleagues examined data on CFRD from the U.S. Cystic Fibrosis Foundation Patient Registry, collected between 2003 and 2018. During this time, screening rates for diabetes among individuals with cystic fibrosis increase, while incident rates of diabetes decrease, which is really good news. However, prevalence rates of diabetes also increased. These findings suggest that more targeted screening strategies could be considered to reduce the burden of current recommendations that individuals with cystic fibrosis undergo annual OGTTs. But it also tells us that more subspecialists will be needed to care for a growing population of individuals affected by this unique insulin deficient form of diabetes.
So it's great that you're highlighting this group, and again, sort of fits in with what we were saying before about being able to be more precise about figuring out one's risk and therefore selectively choosing who needs to undergo the OGTT. Because as anyone who's ever had an OGTT or any of our patients have told us, it's not the funnest test in the world. So if we can be a little bit more selective about who gets it, that would be incredibly useful. So thank you, Mike. Now, my last pick is about our old friend metformin. Dr. Mingyang Sun and colleagues from China and Taiwan evaluated the protective effects of metformin against delirium in older adults with type 2 diabetes using a competing risk analysis of death. Using the National Health Insurance Research Database in Taiwan, they evaluated 66,568 metformin users and 66,568 propensity score matched non-metformin users, and found that the use of metformin was associated with a significantly lower risk of delirium, with adjusted hazard ratio ranging from 0.77 to 0.81, with an interesting dose-response relationship observed with higher cumulative as well as daily dose being associated with greater reductions in delirium risk. The authors propose that the neuroprotective effects of metformin may be related to improved glycemia, improved insulin sensitivity, and possibly anti-inflammatory properties of metformin, all of which, of course, still needs to be ultimately proven in additional studies and perhaps prospective studies. But it's always kind of nice to see an old friend being brought back out for discussion and showing some potentially positive results.
Well, your old friend is indeed the gift that keeps on giving. And it is terrific to see these additional important positive outcomes, particularly with the numbers and long-term use of metformin in our population with type 2 diabetes, prediabetes, and to know that it really has been extremely important for both glucose control and minimizing complications of diabetes in a large portion of our affected population. Well, this brings us to the end of the July 2025 episode of Diabetes Care on Air. Thank you to Drs. Guido Freckmann, Stefan Pleus, and Kenneth Cusi for sharing their expertise with us.
And a big thank you to you, our listeners, for tuning in. Remember that Diabetes Care is continuing to take submissions of original art for consideration to be included on a future journal cover. Don't forget to subscribe to get notifications about new episodes of this podcast. Thank you for listening.